right. We're going to do that one again because that was for the sound.
Yeah, no, it's all good, yeah.
John, can you tell me your full name, what your profession is, and what your role at NTGP is?
Oh, yeah, so you're after my full name and my role in for NTGP and my profession. So, my name's John Kelly. I'm a general practitioner for Lanapoi Homelands Association. It's an Aboriginal outstation service in the remote parts of East Arnhem Land. And I also happen to be the GP supervisor and part-time medical educator. Yeah, like that?
Yeah.
Oh yeah, do it again? Yeah.
Yeah.
No, good, yeah.
John, this is a personal question about your career choices. So what drew you to a career in general?
Yeah, it was a bit of a journey. I started off thinking I want to be a physician, and I trained as an infectious disease physician, and I worked as a staff specialist for a couple of years. But it's funny, every time I did a consult, I'd see, say, an obstetric consult, I'd go, I wonder what that's about. Or I'd see a child and go, I'd like to know about that too. But of course the problem with, the great thing about being a physician is you specialise in an area, but the downside is you don't get that breadth. So decided I might become a GP, and I changed over, I did some training in obstetrics because that was one that kept on being drawn to like a magnet, and I did an advanced diploma in that. I heard there was a job in Gove, and I decided to join the GP college and train, and I never looked back. It's exactly what that rewards me. So, yeah.
That was beautiful. Okay, John, this next question is about, where you're originally from and what drew you to working within general practice in the Northern Territory. So can you tell us a bit about where you come from and what drew you to general practice in the NT?
Okay, so where I come from and what drew me to practice in the NT. So I started off in Sydney, and I'm a city boy, but I did a few locums in developing countries, and I did some work in some of the rural areas, particularly New South Wales, and you just get that feeling inside like, I like this. It's I don't know, you get a lot more, from a work point of view, you get a lot more exposure to different types of conditions and scope of practice that I wouldn't have had in the city, and just the lifestyle I did go up to the Northern Territory and worked in Darwin for a bit, and then noticed the Indigenous population, and I noticed one of the beautiful things about working as a doctor is you get that you can get a close insight into another person's culture. And when I was having those interactions with the Aboriginal people there, I realised I was really fascinated by their culture, and that just a little seed in my mind. And then I heard there was a need for a GP obstetrician in Gove, and my wife and I looked at each other and thought, this might be the way to go. So we went up, and that's how we came to be in Gove, and that's the start of, I guess, my main work in the Northern Territory. Yeah.
And John, what is your journey to becoming a GP look like? So where did you start? What was kind of the beginning, middle, and end of your GP journey so far?
Oh yeah, so my journey to becoming a GP, it started, as mentioned, so I started off as a physician and in infectious diseases, and then I got interested in do you want me to, it doesn't matter if I'm repeating myself? Okay. I'll start that, I hope you don't mind if I start that again, sorry.
It's actually a good thing.
Yeah, okay. So you're asking me about my journey to becoming a GP. I started off as training as an infectious disease physician, and I completed my training, and I worked as a staff specialist. And it's just funny how every time I did a ward round, I'd be interested in the obstetric case or the paediatric case or things that were outside of my specialty, and I was wanting to know about that heart problem or that orthopedic problem, and I guess it was my body saying, I think you need to broaden out a bit, and I was thinking, what specialty can possibly do that? And of course, there is only one, and it's general practice. So I decided to go into that. I had a fascination with obstetrics, so decided to do an advanced diploma in obstetrics. And I thought, as I was doing that, well, I might as well join a GP college, so I did. And so I've basically just continued along that line. I worked in Gove as a GP obstetric doctor whilst completing the fellowship in that. While I was doing that, my wife was working at the Aboriginal Outstation Service of Lanapoi, and she kept on coming home with all these terrific stories about being out there. And one day they invited me out there just to see what it was like, and I think I was hooked. So I went off and started working for them, and somewhere through all that, I did my, finished my exams and as a general practitioner, and that was pretty much I guess that's the journey.
Thank you. What remote supervision is and what it looks like. So how do the interactions between GP registrars and GP supervisors take place? And how do you deliver advice to the GPRs that you're training? And how do the GPRs seek your advice?
Okay, so this is a question on GP remote supervision, what it looks like and how it actually happens. Yeah, so it's an interesting thing because by its nature, you run the risk of being remote supervision is that you might have that dodgy trainee that might look good on the surface, but when you scratch it deep enough, you find that there's problems, and the risk for a practice like ours in the Aboriginal Health Service is that you can do a lot of harm. So we're mindful of that. So the key thing what we do is when a GP trainee starts, we like to get to know them very well. And so what I do is I come up for a week and I just sit in every single, within every single patient and just watch how they go. And we make it an educational thing. The other thing is I want to get to know the person as a person. So often we have the drive up and you get chatting with them and get to know a bit more about them. And I must say, you learn so much. You learn you learn about who they are as a person, how happy they are, and what their goals are, what they want in life. You learn all the bits about their private life that helps you really feel who that person is. And then you can see how they interact with the patient, how they communicate, how they interact with staff, how they are coping with the setting they're in. You can see when they're talking to the patient, how they extract the information, the way they communicate, how comfortable they're making the patient feel. You can see how well they can pick up the cues, the subtle cues of the patient. You can then see how well they can identify the issues, how well they can plan which issues to discuss in the time limit they've got, and then how systematic they are with the actual history in the exam. You can watch exactly how they do their exam. You can see how they work out then what are the big issues, what's the differential diagnosis, what's the plan, and then you can see how well they communicate that through, how they document it in the notes, how well they safety net things. And I just do that. I spend a whole week just doing that. I don't even try to see patients myself, because at the end of the day, if you can do that right, you can get a GP you can identify the problem GP and do something about it in that week, and you can set them on the right course. Because at the end of the day, I think everyone's got that potential to become that great GP, but sometimes they need to have someone really watch what they do. And And ironically, that's I think the key to remote supervision is to do the opposite and be incredibly intensive. Because what you do then, it's like taking off a pilot learning how to fly. From then on, I become more of a mentor. And the key there is to be very available, and for them to know that they can ask a question at any time and that there's no such a thing as a silly question. And in fact, the silly questions I tell them are the best. And what I do is I mentor them through, which means that they go out bush, and every time they get a problem, they can get on the phone or FaceTime, or they can send a picture or send a video, whatever's relevant to that presentation, and that I or my counterpart Joy can field that call and deal with it there and then. And the other thing we do is the phone is only one medium. It's auditory, but so much of the information that you want to pass across is in the non-verbal cues that the patient gives, or the way they extract that information, or how that examination is done. So what we do is we use FaceTime. We pick FaceTime because it's quick, boom. In fact, it works better than the phone because the phones are usually out, and there's outstations half the time anyway. And we just communicate. And if she says, look, I'm really struggling with this history, she puts me on to the patient. Something I should mention is I'm familiar with all these patients. They know me. I think a useful thing is that for a remote supervisor should be someone who's been on site and knows the setting and knows the patients well. Because then the patient, and Aboriginal people really like relationships, knows me or knows of me, and so I can capture that non-verbal cues. We can set it up so I can watch them examine someone's tummy, watch their face if they're if they are clearly showing pain yet the GP's not picking it up. And I can also, it's an educational tool. The GP learns. So for ears we use otoscopes which have cameras in it, so I can see that middle ear cavity, or we'll put the camera into this person's mouth and I can see what that tonsil's looking like. And what we essentially are doing is it's mentoring. It's an ongoing process, and I guess I'm only mentioning my role in it. My role is to do that, and what we do is ultimately you want them to be a pilot that can fly without the co-pilot, and so I let them work within their comfort levels. I know what their threshold for calling is, so I know them, so I have a trust, and the idea is you let them take off on their own. So they know I'm there, but they can call me. But if they don't need to, they can continue on. And in terms of the rest of it, we have a whole team, and the team is we have Aboriginal health workers, we have the nurses who are the real cogwheels, along with the Aboriginal health workers of the whole service. We have my other GP counterpart who does similar thing to me, except that she does some on-site work at times with the GP. And we have our allied health who come through, and they all have incredible roles in the whole process too. So, for example, the nurses have the relationship with the patients. They know the context, they know the backgrounds of every patient's problem, and it's something you can't get from looking at a file. And they will look at that stuff, and they will teach the GP trainee about all that stuff. And in doing so, they help the GP understand that the context is important. They teach them a whole bunch of procedures that I learned from the nurses, like how to use a tympanogram, how to use an INR machine, how to do a sugar test, how to do an injection, how to do an ECG, things that GPs don't often do. So they also have that how to use a tympanogram. So they in doing so add a huge amount to the GP trainees' training, and they feed back information to me about the GP. So I know how they're going from their perspective. The Aboriginal health workers they're the cultural mentors, and none of us can function without them, because they actually know how people really think. They know what's going on in that community, the cultural context, the relationships, things that as a non-Aboriginal person, I can't even fathom. And so, for example, I wouldn't see a mental health patient without one of them. And so they add a tremendous amount again to the GP's training, and their realisation of the importance of the cultural cues, and so they learn that. And allied health come through. When their allied health come through, we'll roster the GP trainee to see how the physio does things and how the podiatrist does things, because at the end of the day, health is well beyond what a doctor does, and including and also the nurse. So we tap into that. And the only other thing I'd say we do is I do periodically check the files. When we're going through pathology in the office, I enter the computer through TeamViewer and physically go through the results with them. And again, it's like taking off on a plane. I won't let them take off on how to do, say, look at a lipid profile until I know that they can look at a lipid profile and how to look at it. And then again, I let them take off. And because I think if you don't do all that, people's morale drops. They feel like they're a dumb doctor, and we do harm. And because at the end of the day, I want them to be happy, find it incredibly rewarding, and because if they're rewarded and happy, that's going to be great for the patients.
Yeah. I think you answered just about all of the questions in that. John, can you tell me how the training experience is different for trainees under remote supervision compared to more traditional models where the supervisor might be in the next room?
Okay, so you're comparing remote supervision with the GP setting where they're in the room next door. Yeah, it's I think there's pros and cons for both. I think there's merits to both. My main experience, of course, is in remote GP supervision, so it's hard for me sometimes to fully compare with how the city GP setting is. But I have done a little bit of, I've done a lot of observations as a medical educator in the city setting. So, and I did work for a little while in that traditional setting. I think the main, the remote supervision on the surface might sound like it's a bit dodgy. Like, how can someone supervise from, it's 3,000 or so kilometres away? Is that right? I don't know how the distance is from Sydney to Darwin. But anyway, but it's interesting because there's a few fundamental differences. Number one is we're very mindful that it's remote supervision, so we put in a lot of extra precautions that may not occur to a city GP setting. So we actually do spend a week directly observing a GP trainee on every single patient that they see, and I don't think that occurs in the typical city setting. And we do it for a good reason, because at the end of the day we actually save money and time, because that GP usually tends to take off pretty quickly after a while, and we don't have to spend as much time. Another difference is we are very available when they're taking off, as I might say, in terms of their learning process and learning through experience. It's nice to have someone who is around the corner who you can ask questions about, or check how to manage a patient. The problem is that the reality in many city GP practices is that the GP next door isn't available. They're seeing a person at that point of time, and they can't just stop what they're doing. And as a result, the GP, even though he's next door, can't actually access that person. And when they do see them, it's very brief, and it might be just seeing the key points of the patient and then giving a quick advice and walking out. Whereas in our setting, most of my time I'm doing administration work for the health service, waiting for the calls. I'm not seeing patients at the time, so we're very available, and so we can quickly tap in, and that's really good for patient care, because the patient gets to see what's going on, gets their problem fixed quicker, and there's less room for error. The other thing we do is we have a variety of technologies that wouldn't normally be used in a GP setting that we use because it gets around the barriers of remote supervision. So we use FaceTime routinely. We use teleotography, which is taking photos of people's middle ear cavities routinely. We take videos and photographs of people routinely, and these are not things that GP practices have. They won't have teleotography, which is taking the photo inside someone's middle ear cavity. And the other thing is that in the Northern Territory, people are very aware of our setting and the remoteness, and they're sympathetic to it. So as a result, we have these great relationships with a variety of staff in the hospital system. So when you see that photo and I go, oh wow, that needs an operation, we just send it to the surgeon. They say, yeah, that's good, let's put him on a theatre list. If they see that, we once had a middle ear thing where there's a nasty condition called a cholesteatoma. One of our nurses sent a photo, said, what's that? I said, oh, that looks like a cholesteatoma. We sent it to the ENT surgeon and they were able to fix it. And if I don't know what it is, I just send it on. Videos, some of them will accept FaceTime. It's unofficial from a hospital point of view, but because there's that relationship, they do it. And the winner is the patient, the trainee learns something, I learn something. It's a win-win. It saves money. And I think the other thing that's really important about our setting is that patients don't like going all the way to Darwin to see specialists. And quite frankly, the health system doesn't like to fly people all the way in to see specialists either, because it costs a lot of money. And as a result, we get a wide breadth of health problems that we manage and that would normally be managed by a specialist. And I think there's a truth that the more you get exposed to, the better you get at it. And so our GP trainees get exposed to a whole variety of conditions that they'd never get exposed to in a city GP practice. And yet they've got the safety of a GP supervisor, a sympathetic health system that's quick to respond to any questions we have. And so as a result, our GP trainees become extra skilled in things that they'd never get in the city GP practice. And I think the last thing is is that in general practice, you get exposed to a variety of cultures and different ways of seeing the world. And one of them is our Aboriginal people who do have a different worldview on life. It's a beautiful worldview. And the place you're going to get exposed to that in the true sense is going to be remote settings where remote supervision is probably going to be the only way to get these trainees out there. So, I don't know, I think I did say there's pluses and minuses. I'd say the one negative is that there are some small aspects of physical examination that I can't really tell looking at on FaceTime. If someone's got a mass in their belly, I'm not going to be able to feel it. I think heart sounds and breath sounds I can't really hear, although we are now trialling audio devices that I can hear those things, but there are limitations. But I think overall, if you look at the pluses and minuses, I think it's well and truly, in my books, puts remote supervision in a very strong position for trainees.
That was beautiful. Like yourself, would be complemented by the on-site supervisors.
Okay, so this is a question on how my role as a remote supervisor is complemented with the role of the on-site supervisor. I think they complement themselves quite nicely. In a sense, we both do a similar role. Because when we go out to remote communities in 2x2, our on-site supervisor may not be in the same location as the GP trainee. So in some ways, she does the same things as I do. Having said that, she will also do a fair bit of on-site sitting in the same clinic as the GP trainee, and we do definitely roster that on. One of the limitations to remote supervision is that some aspects of the physical examination are hard to attain through the internet, And our other problem is that there are some centres we have that don't have internet appropriately functioning, so a lot of the advantages of the internet are lost, such as being able to do FaceTime. So that's where our on-site supervisor comes in, and also sometimes it's nice when you're doing, say, family conferences to have someone mentor on site to help the trainee learn how to deal with those situations. So I think they're probably the key areas that our on-site supervisor has, and I think that's why it is good for a health service to have some degree of on-site supervision. So you wanted to know about the challenges faced in working with for health in Aboriginal communities in the Northern Territory. Yeah, there's a number of challenges. In the Northern Territory, a lot of Aboriginal people live in very remote communities. It's a wonderful thing. It's one of the rich sources of culture, where a lot of the ceremonies take place, where there's a lot of the cultural heart. In some ways, it's a cultural heart of the people in the area, the very remote areas, which makes it very special. But the challenges are that Aboriginal people have a lot more health problems. Some of the health problems are conditions that are not experienced by GP trainees that may have come from the southern states, because they don't occur in those states as much. They often have differing views sometimes on health, or differing views on how conditions are interpreted, which if you don't appreciate that, could mean that we're ineffective. They have English often as a third language, and many of our health concepts don't exist in their language, just as many of their wonderful concepts don't exist in our language. And as a result, there's a great challenge for all health professionals in trying to explain conditions. Another problem is that people are incredibly mobile, and so you might see them in one community, but the next moment they've gone with other family to another community. And I think the other thing is that their views on life are quite different. They come from a very different angle. They're much more, the individual's not the important one, it's the community, it's the family. If you want to make a decision, help the patient make a decision about whether they need dialysis or not, it will invariably, they'll want 20 people to come into a room, and the decision maker may not be the patient. And in a way, it's a wonderful thing, this community mindedness, because there's this real interest in other people and relationships, so much so that if you live in a place long enough, you get adopted because they want to know what relationship they are to you, and it's quite a nice thing. But these things can be quite challenging for a health professional who might have different values and understandings of the world. And the other problem is it's remote. It's expensive to fly people in to tertiary health services, or it can be expensive just to get primary health services into some of these communities. And that's a challenge. Both the patients don't like it, our health service doesn't like it because it costs a lot of money. And so these are things that the barriers that we need to get around.
What skills do GP registrars working in remote areas develop higher levels of proficiency compared to metropolitan counterparts?
Okay, so the question is about what skills GPs training in remote settings obtain over the city GP. I think there's quite a few. One is that its access to specialists is quite hard in remote settings. So you turn out managing a lot of conditions you wouldn't normally manage as a GP to that setting. In a city GP setting, they'll often get referred early, and you never really get to make decisions or get exposure to those conditions in the full sense. So, and I think the more you get exposed to something, the better you get. So as a result, I think our GPs become a lot more proficient in a lot of these conditions that would be normally managed by specialists, and therefore they get better at it. Another thing is that a good GP needs to be flexible and culturally aware and be able to adapt and understand the local resources. And I think in a rural and remote setting, particularly with Aboriginal people where the culture is quite different, you really get thrust into that. And it's the same thing. The more you get exposed to it, the better you get. And so, for example, I spend my whole time looking in Aboriginal communities, talking to people where English is a third language, where the concepts that we use are not necessarily in their language. And so I've got to spend all my time thinking of ways to get better at that, and active listening, really carefully trying to pick the cues. And I think those skills, when you go to a city GP practice, are fantastic. You know, when I've worked in a city GP practice, having worked in an Aboriginal health service for a little bit, and suddenly I realised my communication skills are vastly better than they were before. I think another area is that in our remote settings, particularly the remote supervision setting, we make use of a lot of devices like photographs, FaceTime. We use photographs inside people's ears called telehealth, and we have this because it is remote supervision, we have to counter that. We not only have these devices, we have quick access so that they can communicate to someone else about the problem with the patient in front of them. It might be me as a GP supervisor. It might be that we send it to what's a very sympathetic health service up here, who are very aware of our remoteness. And as a result, you learn to get skills in things that you wouldn't normally get skilled in. So for example, if I use the example of ears, by virtue of us being able to take photos of someone's middle ear cavity, they can send a photograph of that ear, or I can see it live on FaceTime, and I can afterwards put that photograph into a PowerPoint. I can put little marks to all the anatomy, where everything is, exactly where the pathology is, and send it back to them. And they come out learning how to look at a middle ear in a vastly superior way to what they get normally. And if I don't know what it is, I send it to a specialist and I learn, which is all the better for the GP trainee, because I can, they learn what that specialist learns, and next time I get that problem, I'll know to give a quick answer. Yeah. So who would be best suited for a remote supervision model?
What kind of person?
I think it's a remote setting, so inherently I would like someone who wants to be there. I think that's the key skill. If they have that, I think we can turn them into a great GP. I think it helps to have had some experience. I think the more experienced the GP trainee is, the easier my job is. But I think my answer to that would be, it just means that we might need to spend a bit more. If we've got the resources just to spend that greater length of time at the start observing them, I think they'll catch up. And I wouldn't discount them for that sort of style of learning. Yeah.
And we'll go back to that question that you raised as well. So
Yeah, sure.
what makes a good doctor?
Okay. So the question is, what makes a good doctor? I think, for me, if I was a patient, I would want a GP who's happy, who's feeling fulfilled, who's coming to work with a spring in their step because they like being there. And the reason for that is if they're balanced and happy, from a patient point of view, they're going to listen to that patient and be more empathetic and get to the root of the patient's problem and help them. I think I want a GP who does know how to interact with a team and understand that we're not all going to have the same view on how to do something. There's more than one way to skin a cat. I think and we all have different psychologies and different buttons that are pressed, and I want a GP that can understand that, not take it personally, and be able to even enjoy the interactions. And I want a GP who can make a patient feel welcome, and establish a therapeutic relationship where that patient can express what they want to say, even the dark things that they wouldn't normally say to someone, if that helps them solve their problem. I want the GP who can do that in a variety of settings, whether it be a language issue or cultural issue. For example, the Aboriginal people, where they have both often. And I want a GP who can understand that the setting you're in and the culture you're in profoundly alters how you manage someone and the resources. And because I think because the setting's always going to change and to wherever they work, and it is different. I want a GP who can identify the main issues with the patient, who can work out what the issues are for that consultation, be able to plan it in a time-efficient way, so that they know which issues we're going to deal with in that time slot, and can make that agreement with the patient. I want a doctor who can take a systematic history, who can establish a differential diagnosis, work out the problem, work out the ideas and concerns of the expectations of the patient, who can know the impact that the condition's having on the patient and what's been done about that. I want a doctor who can examine a patient well, who really can get to find the physical signs that are relevant. I want a doctor who can work out what the likely causes are, the differential diagnosis, the uncertainties behind it, and be comfortable with the uncertainties, who can do relevant, sensible investigations that are relevant for that patient in their context, and who can make agreed management plans with the patient where they can empower the patient to be in charge of the condition, where the patient doesn't feel disempowered, because patients are disempowered people from the very outset, and it's a very vulnerable position, and we can lift that and make them in charge of their condition. I think that's a fantastic thing. And I want a doctor who can communicate, who can extract history with open-ended questions and all the techniques that good listening, who can really extract the information correctly in that patient, and who can communicate the findings well with that patient, and in their context, knowing, and who can be innovative. And I want a patient who knows what the management is in a setting, who knows their local guidelines, but also knows what could be, and is innovative and pushes the boundaries, because many of our treatments are a little bit substandard to what could be potentially in our setting. Sometimes we get used to this treatment because we say, well, that's all we can do in this setting, but to think, well, could we make this a better world? Could we do something different? Yet I want a doctor who can accept and doesn't get frustrated by what is, who can accept what is at the same time. And I think most of all, I want a doctor who's a human being and who can always be comfortable with their own frailties, their own weaknesses, what they don't know, and to embrace what they don't know. Because if you don't know what you don't know, you never learn. And who's comfortable to openly express their vulnerabilities, because that's part of being a human being. And I think at the end of the day, people really appreciate that.